Well, hello and welcome. I'm sorry for the late start today. We had a couple of minor technical issues, which fortunately we don't have too often, but sometimes those things happen. My name is Guy Stevens. I'm the founder and executive director of the Alliance Against Seclusion and Restraint. Really happy to have you joining us here today. Very excited about our program today. As always, I really enjoy these and I hope you do as well. For those that might not be familiar with the Alliance started about 3 years ago. We began really trying to raise awareness about the use of restraint and seclusion in schools across the country. Over those 3 years, our mission has continued to grow. We're really interested in things far beyond seclusion and restraint. We're interested in, of course, restraint and seclusion, also suspension, expulsion, and corporal punishment that might be happening in schools. But even more broadly, we're interested in all the things that are happening often to people in the name of behavior. And a lot of the approaches that are being taken that are really harming to a lot of individuals. And we're seeing a lot of very bad outcomes, even kids getting pushed down kind of the school to prison pipeline. So our vision is not only about safer schools, but we want to see less approaches like restraint and seclusion everywhere that they might be happening. So today I'm very excited to have Dr. Alex Klein joining us. Alex is going to be talking a bit about neurodiversity-affirming care. And I'm really excited about this. I got an opportunity to meet Alex, well, probably about a year ago. Really have a tremendous amount of respect for the work that he's doing and really excited about this. I do want to remind you, if you have questions during the interview, what we're going to do is we're probably going to take most of the questions at the end of the presentation. However, you're free to ask those questions anytime you might have them, and I'll try to keep an eye. And as things wrap up, I'll try to go back to those questions. So don't be afraid of losing your question. Go ahead and put that in the chat at any time, and we will try to get to those as we get through the presentation. As always, today's session is being recorded. So it will be available on YouTube, on Facebook, and as an audio podcast. So you can always go back if you missed part of it and listen to it later. Before we get started here, please feel free in the chat. Let us know who you are and where you're from. We'd love to know who's on today. And with that, let me go ahead and introduce Dr. Alex Klein. So Alex, welcome and thanks for joining us. I'm going to give a little bit of a background on who you are. And I know that right now you are looking at us and also looking at your presentation and ready to go. Dr. Alex Klein is a licensed clinical psychologist who specializes in child and family therapy, neurodevelopmental differences such as autism spectrum conditions and ADHD, as well as parenting. He received his doctorate in clinical psychology from the Wright Institute in Berkeley, California. He's trained in child, adolescent, and adult psychotherapy and assessment with clients who present a range of diagnoses. He's worked at the Kaiser Permanente in the Oakland Medical Center and also has a private practice. His primary interests include neurodiversity-informed care, couples and family therapy, parenting challenging children, pathological demand avoidance, social justice, trauma, education, and the supervision and training of graduate students. A former teacher and school-based therapist, Dr. Klein consults with school districts to help develop more appropriate learning environments for challenging students. Dr. Klein's greatest joys are spending time with his family and friends, music, exploring the outdoors with his wife and twin daughters in the Bay Area. So we are really excited to have Alex Klein joining us today. As I mentioned, I got a chance to meet Alex probably a year ago, maybe a little less, doing a training that we were both doing through a mutual connection, which brings us back to the pathological demand avoidance. Diane Gould, who had introduced us on the training that we attended. So Alex, a huge welcome. Really excited to have you here today. Really excited to have you talking about what you're going to be sharing with us today. So a big welcome from all of us.
Well, thank you so much, Guy, for having me. And I also really want to thank you for the work you are doing with the Alliance Against Seclusion and Restraint. It's, of course, work that's really near and dear to my heart and really, really important work. And I think fits in nicely with some of the concepts that I'm going to be talking about today. So thank you as well.
Absolutely. No, I appreciate that. And it's so nice to have so many amazing allies and professionals out there doing really fantastic work. And, I kind of look at this as there are a lot of things that need a lot of help out there, but it's always great to know that there are people like you that are, working to train others and doing great work. So what I'm going to do is I'm going to bring your presentation up on the screen here, and we're going to let you take it away. I do want to let you know real quickly as I'm doing that, we've had a couple people that have already said hello, and I'll just share a couple of these real quick. Ruth Ann said, I'm autistic young adult. I'm extremely passionate about educating people on disability-related topics. And hello, Ruth Ann, and thanks for joining us. Have Diane Cruz here from Chicago, unschooling her 8-year-old autistic and ADHD son. Let's see, have Kayashan, who is a music theorist. Listening to children is important. So we have a couple people that have already said hello here. But with that, I am going to disappear, let you take over your presentation. And if you need me, I'll be here. And of course, I'll be monitoring for questions that might come up. But we'll let you take the reins, and I will be back with you as you're wrapping up, and we'll get some Q&A done.
Great. Thanks so much, Guy.
Absolutely. Take it away.
All right. So the title of this presentation is Neurodiversity-Affirming Care in Autism. And I really got interested in this question, what does it mean to be neurodiversity affirming? A long time ago, back when I was doing my doctorate, and my dissertation topic was essentially I was interviewing young autistic adults about their experiences with therapy growing up, their experiences with the therapists, qualities they looked for, qualities they did not like, therapies that were helpful and not helpful. So I've been really interested in this topic for a really long time, and really trying to sort of dedicate my career to some extent to sort of amplifying autistic voices and being an advocate to the community here. And the key questions that I want to get into in this presentation today are really about how can we reframe our understanding of disability and the autism spectrum? How can we do better in assessing autism, and how can we do better supporting autistic people and their families? And I think while there's been some moves in the right direction, I think we have a long way to go. And a lot of you, I'm sure, run into a lot of the challenges along the way in your programs being neurodiversity affirming. So we'll get into that. And the first point I want to emphasize is how important it is to listen to autistic people. I do still see this in professional circles, sometimes with parents and schools, where some of the sort of ideas and criticisms about therapies that have come from the autistic community, I have noticed that sometimes people get kind of defensive or don't want to really kind of take that in. And I think that's a real issue. We need to really be aware of the power dynamics at play in this dynamic. And also, we want to really prioritize and amplify the autistic voices and really let them lead the way here. So I first want to start with talking about what I see as the key shifts in neurodiversity affirming care. And the first point that I think is a really crucial one is what I'm calling moving from won't to can't. I think some of you might know what I mean here, but I want to explain it in detail, right? So there's a very common misperception that kids are struggling because they just won't do better. They won't behave. They won't stop yelling, for example. And the shift, and this largely comes from Dr. Ross Greene, who wrote The Explosive Child, and I'm going to talk more about that as an approach I really love, and the approach of collaborative and proactive solutions, and sometimes referred to as collaborative problem solving. Dr. Greene wrote, kids do well if they can, as a contrast to kids do well if they want to. And I think this is a really critical shift in framing that really influences in a positive way the way that we understand a kid's challenges, and it influences the way that we respond to a kid's challenges, right? So if a kid won't, if we think a kid won't respect us or won't listen or won't, stop banging on the table, during math class, or are we saying, well, a kid, this kid right now, they can't regulate their emotional state. They can't manage their impulses. They can't be flexible in the way that we want them to, right? And that's a much different framing. So I think that's a really important piece. Another important shift, I think, is the move from control to comfort, right? So I think that there's way too much efforts to what I would say over control kids who have difficult behaviors and have difficulty meeting adult expectations. I also thought this could be called, moving from correction to connection. I think I see this as sort of similar, moving from control to comfort. And I think when we find that kids are really struggling, oftentimes we see actually a ramping up of efforts to control and correct a child's behavior. And I'd say that that's a misguided attempt and missing the mark. And I think that these are kids that are being misunderstood, and that we need to be offering more opportunities for connections, stronger relationships, more comfort, and this kind of thing. I think another important shift. So I kind of use this as an example. It's more specific. The move from whole body listening to any body listening, and what I mean by that is some of you might have heard of how this is something that's maybe encouraged from students or in any kind of social interaction or a social skills group, or what you're like, no, we want to turn your body here, look at the person in the eyes. Whole body listening. This is what it looks like. And so, moving away from that what's implied in there is that there is one right way to show that you're listening, or that there's one right way to be. And a neurodiversity affirming approach gets out of that and say, well, actually, this can look in different ways. And maybe some kid needs to be, spinning in their chair back and forth, or, spinning their fidget toy, and actually needs to be kind of pacing back and forth a little bit. And it doesn't mean necessarily that they're not listening, right? And there's not one right way to be, right? The sort of neurotypical whole body listening is not the ideal, right? So kind of getting out of that framing, I think, is an important shift. Another shift that I'm going to go into a bit more detail later on is the shift from external behavior, looking at what are the external behaviors, to what is the internal experience of the child. We might hear, this kid eloped, right? This is a term I hear a lot, to refer to ran out of the classroom or something like that, or ran out of, and like, this was the behavior, and this is what we're hearing about. And then, a school or whoever might develop a plan, right, to try and deal with that. But when we shift to, what is the internal experience of the child, we're really looking at, like, well, is there some sensory overwhelm going on? Is there a feeling of shame about not understanding the curriculum? Is there some bullying going on that we're not really seeing? Like, what is going on internally for this child? And really moving from focusing on the behavior that we see to the internal experience of the child, I think, is an important shift. And I think another important shift, and this is from it has to do with flexibility, and this is not having to do with the flexibility of the child per se, but the flexibility of the adult in working with the child. So I think that a lot of times what we see is, for children who have difficulty being flexible and very persistent in their beliefs, and can be met with kind of an inflexible adult stance to, that we must do A, B, and C, and this is our plan, and these are our expectations, and I cannot deviate from that because that's wrong, or that's not how to be. And I think that leads to a lot of problems. So what I want to see is sort of more flexibility from providers, from parents, therapists, schools, teachers, all of the above, right? I think we meet inflexibility with more flexibility from the adult, who may likely has the ability to be more flexible than the child has, who, again, it's not that they won't be flexible, they're not choosing to be inflexible, but it's that they can't be as flexible as we might want them to be. And in the context of, so this is April, this is Autism Acceptance Month, moving from awareness of autism, and there was some early campaigns that have been criticized by the autistic self-advocacy movement about, I remember back in New York seeing billboards that would say things like, beware, autism is, increasing. We must, you must give money for a cure, right? So, like, be aware, the numbers are this, the numbers are that. This sort of fear-based cure rhetoric, which I think is really problematic, and moving to a place of accepting that, neurodivergence, autistic people are part of the human genome. They've always been part of the human genome, and they always will. And we need to accept, the strengths and the challenges that comes with. Another key shift, I think that's really critical, has to do with the shift from independence to interdependence. And what I mean by that is oftentimes, we hear that, independence is like, this is this gold standard that, like must be, independent. And if a kid is not independent, then like you've failed as a parent or the school or whatever, right? And, that's a values-based framework that I don't think is necessarily helpful. Like, what if the goal becomes more, how does the child learn to advocate for themselves? Or how does the young adult know, like, well, when they do need support, and, and why is that a bad thing? Right. So that's another important shift I wanted to talk about. And, getting this links to what I said earlier about, moving from external behavior to internal experience, is moving from the what to the why. And what I mean by that is, I can't tell you, this is kind of a pet peeve of mine. I will hear from parents, for example, that, a therapist or a teacher or somebody kind of emails them saying, like, your kid threw the pencil at the other kid, and your kid, like screamed and, kicked me out, out on the playground. And, like, okay, I mean, it is important to know when things actually happen and when incidents occur. And as you do in your work, Guy, really importantly, sort of not just advocating to eliminate seclusion and restraint, but for schools and programs and facilities to actually document accurately when it's happening. So I do think there's some degree of like, well, we do want to know what's happening. But what I think is a more important focus is, well, why did this behavior occur in the first place, right? Because if we don't understand why the behavior occurred, that, okay, this is about a difficulty with flexibility or transitions, sensory overwhelm, an adult who maybe was picking the wrong battle, and a kid who, is having some transitions going on at home, and that's influencing behavior at school and sleep and medication change, whatever other things are influencing where the child is at in this particular time. Like, that's an important conversation to have, not a laundry list of all the bad things that the kid did, right? So I want to move away from that. And along those lines, I want to just get attention-seeking behavior, like, just out of the vocabulary. I no longer think that should be used, right? Now, I know that there are, some times where somebody might, my 3-year-old might do some, connection-seeking behaviors, wanting to see how I'm going to react or something like that, right? But I think, first of all, I think I want to think of these things as connection-seeking rather than attention-seeking, because when we think of it as attention-seeking, oftentimes the recommendation becomes ignore this behavior that is actually often connection-seeking. And that is not a helpful framework to actually help kids, to actually know what's really going on with them, to get into well, why are they doing this behavior in the first place? So I want to move away from this attention-seeking stuff. And then lastly, I think one of the most critical shifts really has to do with changing the system, moving and not changing the child. So change the system, not the child. And what I mean by that is that there's just so much emphasis on, this is what the child needs to do better. This is the behavior that we want to see from the kid. This is what the kid is doing wrong, right? I'd rather have behavior plans that focus on adults and what adults can do to respond to challenging behaviors. I think that's actually more important than a behavior plan for the child in some cases. And yes, the behavior plan for the adult may ultimately help and probably will ultimately help the challenging behavior we see from the child. But again, I think that when we over focus on changing child, it really, gets into the difference between a medical model and a social model of disability. In a medical model of disability, we think of the problem as being located within the child, and we need to remediate the deficits in the child, right? When we talk about a social model of disability, which the neurodiversity movement advocates for, it's like, well, there's larger problems in society: ableism, policies on on a local national scale, the school systems, the family system. Like, these are things that often we're going to really need to focus on. How are the systems around the child understanding and supporting the child, rather than so much focus on changing the child themselves. So we want to see a shift in focus there. Another thing that I think is important to think about in the way that we talk about the autism spectrum is that, many people who are sort of knowledgeable at autism could tell you, like, some of the criteria, some of the deficits associated with autism, but how many people can give a long list of some of the strengths associated with autism? Not as many, right? It's going to be many more people who are going to be giving a much longer list of the deficits than strengths. And we do know that there are strengths associated with autism: long-term memory, the ability to memorize new information, pattern detection, the ability to, hyper focus, sometimes referred to as monotropism, and to really kind of get very focused on a certain thing. That can be a strength in some contexts, right? So Greta Tunberg here on the picture talks about that a bit as well. And the language really matters here. I think that, when you look at the language in the DSM, that's the diagnostic manual we use for diagnosis, things like rigid, right? Like, could we say, well, actually, okay, like, so how does your child show persistence, right? Or do they have a strong sense of justice? Are they exacting? And sometimes these things are strengths, and sometimes these things are challenges. And we just want to be careful not to only talk about these things in terms of a problem, right? And this piece here where I have high need for control, right? So a lot of times I might hear, oh, he's controlling. Oh, she's too controlling in play, or oh, they do this, but if we say, like, actually, he really has a high need for control, in these new environments where he just doesn't know what to expect. And, with kids, he doesn't really know, and sort of helps, it's really high need for control that helps him manage anxiety, right? That's that kind of elicits a different reaction from us if that's how we talk about the issue, as opposed to saying, like, he's too controlling. This is difficult, Again, language from our diagnostic manual: highly restricted, fixated interests that are abnormal in intensity, right? When we ask about these when we're assessing kids, like, what if we ask, like, what kind of expertise and what does your kid show passion for? That's just a different way to talk about these things, I think, is important. And even with something like, your kid can't transition. Well, like, does your kid go really deep into their experiences? Doesn't want to rush through life? What does that look like? Again, I think that the language we use to ask about symptoms when we're doing assessment, if we're doing, therapy, hearing about challenges, can influence the sort of amount of a negativity a kid and a family takes in. And I think that we really want to talk about neurodiversity-informed care as trauma-informed care. And I think a lot of clinicians say, we're trauma-informed, and I understand what trauma is. I think we really want to make sure we're going deep into that with the autistic community and understanding where this is coming from. So, there's a study where, autistic people were interviewed and filling out scales, and it showed that almost half were experiencing post-traumatic symptoms. Right? That's extremely high, way higher than the non-autistic population. We know that bullying is really, really high, much higher in the autistic population. It's a really critical thing to be addressing. We know, and can absolutely be experienced as very traumatic. We know that sensory assaults, not just a kid who acts, for, something becomes louder than they were hoping because the fire alarm went off, but there's even practices that still exist today where, kids are being asked as a way to try and desensitize them to sensory experiences, where kids are being, forced or, strongly encouraged to stay in these environments that are sensory way too overstimulating for them. No, that is not helpful, nor is it ethical. It does not work and can be experienced as traumatic. And some autistic adults are talking a lot about ABA and harmful and traumatic experiences they have with that. where their stimming behaviors, which were used for self-regulation, were suppressed, for example. And the history in and of itself, just knowing the history, we want to, there's a lot of trauma in the history of autism treatment for parents. It was only 50 years ago, 40, 50 years ago, that the refrigerator mother theory of autism was like the prevailing view in the States, that like the cold mothers who were not warm enough with their children caused their kids autism, right? This ridiculous stuff that we know is untrue. There's seeds of this that, persists these days. But, I think that in the history of the way autistic kids have been treated with punishments throughout history and to this day, there is a lot of trauma. We really want to be aware of that. And, and Guy, I know that you have talked about this, the seclusion and restraint, right? Like these are, a lot of people will say that these are necessary, required practices that we have, there's nothing else we can do. And I would suggest that is extremely rare that that's the case. Like the very low percentage of seclusion and restraint practices were really necessary to prevent severe life-threatening injury. And those practices, we also know, are traumatic, right? So we want to be really informed and really know what's going on here. Applying an intersectional lens. This is really critical to think about. How do autism, gender, race, and other identities intersect? So we know that Black and brown children are diagnosed later than white children. We know they're more likely to be misidentified, maybe get a label of oppositional defiant disorder, which, frankly, as far as I'm concerned, I want to just abolish that diagnosis, but it's in there. Not identified accurately, not seen as, maybe seen as more aggressive than they actually are. Not be the neurodevelopmental roots of some kids of color, not being, the neurodevelopmental roots of the behaviors not being identified accurately. Girls and women, we see higher rates of assault. We know that women face more pressure, girls face more pressure to mask and camouflage certain maybe social differences or autistic behaviors. And that has a real cost to it. I'm going to talk about that a little bit later. And we also know that there's a high overlap of the trans and non-binary and gender expansive community and autistic identities, right? So if you are autistic, way more likely to, belong to that community than the non-autistic community. So that is important to sort of know that this overlap is occurring at pretty high rates. And critically, that we're not using the autism diagnosis as a reason to not allow for gender affirming care, which is very important, that we do want to allow for that. So, and as Guy, as you mentioned earlier, PDA, right? We did connect, through Diane and talked about PDA, which is not, what is it? Public displays of affections. Not that. This stands for pathological demand avoidance, and sometimes referred to, and I like this way of putting it, as a pervasive drive for autonomy. I think that the reason that so this is considered a subtype of autism that's largely used in the UK. It is not an official subtype, it's not an official diagnosis, but is thought of as a subtype of autism where these are kids who is an anxiety-based resistance. And the anxiety-based part is really critical because, again, we want our framing as, okay, this is a kid who's having trouble regulating anxiety and stress as opposed to purposely oppositional behavior, right? So anxiety-based response to the everyday demands of life. So this could look like, getting, when, it's time to come to dinner, right? So like, a kid, something as sort of benign as that might be perceived as a threat, right? And in doing it and saying, let's come to dinner that way to this child just isn't going to work that well, right? Or even the internal demand of like feeling hungry or feeling tired. If one has the interoceptive awareness to read those cues, we know interoception and understanding internal body cues can be difficult in the autistic community. But let's say they are reading those cues, even that can be perceived as a demand and a threat to their sense of autonomy. And the reason I think that understanding PDA fits into a neurodiversity-affirming care framework is because a lot of parents I see are getting really crappy advice from professionals about how to deal with their kids. And I think simultaneously, some kids that are not getting diagnosed with autism but should have gotten diagnosed with autism, parents are coming across in some cases this PDA diagnosis, say, hey, this is actually, my kid is actually autistic, and they are this PDA subtype. So I think it is important to understand this profile and how it plays out and how to work with it. And I have a resource at the end of this presentation, but the PDA Society in the UK is a really good resource for that. So I really want to rebuild assessment practices, as I was saying earlier, and it's not just the really long waits, that, before diagnosis in some states, months and months and months or more than a year, it can be really, really long waits before assessments. But I'm really talking about, this deficit focus, in the such a strong deficit focus that I hear constantly. So for example, a question in one of, the questionnaires might be something defective like, how does your child play with toys in abnormal ways or something like that, right? Like that's a very pathologizing way to put it. Sometimes these questions are asked in front of the child. We don't want to assume that they are not understanding what's being said about them or to them. I think professionals assume that too much. You want to presume competence. But asking these questions in these pathologizing ways rather than, does your kid tend to, think more about the inner workings of the kid, and maybe this is their, a little engineer in the making, or the inner workings of this little toy, and they like to see how it works and some of the nuance there, or are they doing pretend play with it, or what kind of stuff are they doing? You can ask questions in a different way that again gets out of this sort of pathologizing way to do it. Or like, does your kid flap their hands in abnormal ways? Like why not just ask, how does your kid show excitement? What kind of body, with their body, how does that look? Like so these are a little bit subtle, these differences, but I think it's a far less pathologizing way to get at the questions. And okay, another big pet peeve is, I've been running into this in my practice, assessing adults, but definitely with kids too, where parents will say, well, I told the pediatrician that, I thought my kid should be assessed for autism, but, the pediatrician says, oh, but, she made eye contact with me and like, shows empathy when you got hurt. Oh, no, they can't be autistic. Or like, oh, but he's got friends, like there's no way he could be autistic. He's got friends. And this is really about stereotyping. And because of course somebody can be autistic and have friends and be autistic and make eye contact and be autistic and show empathy, right? Some of these things might look different. But, like this sort of blanket ruling out of autism evaluation based on these stereotypes is something that is really commonplace and really problematic and comes from, I think, a negative stereotype about autism and a misunderstanding of autism. We want to understand the impact of masking, right? So that's what I was talking about earlier, camouflaging autistic traits, being told, okay, like that doesn't look appropriate, so let's not do this thing, this movement, that is something that you need to regulate your anxiety. That has an impact, right? Or pretend, encouraging kids through social skills training to kind of pretend like they're neurotypical in some way, to pretending to be something they're not, that's harmful, right? We want to understand that these things have an impact on a kid's sense of self, well-being, has impact on anxiety, depression. We know that there's higher rates of suicidal ideation in the autistic population, and this is really serious. We really want to take this seriously. And again, how can we be more accepting of difference instead of trying to change the child so much? And I want to de-emphasize functioning labels, and I understand why these are used, like the high functioning, low functioning, these kinds of terms. But, I think when we hear like, oh, this kid's, he's a low functioning autistic kid or whatever, then it's like, that can lead to, first of all, people can look different in different settings, right? And so like, it's not actually a useful term for the child in every case, pretty much, that I come across. Secondly, maybe if they're called low functioning, then there's an assumption that they don't understand what's being said to them or something like that. But maybe the kid actually does, or communicates in a different way, or through their AAC device, in a much more advanced way than we knew about. And so, like, sort of putting somebody in a box of like, you're low functioning, not accurate, harmful. And similarly with high functioning, which we hear a lot, it's like, well, your kid's so high functioning, I don't even know he's autistic, or, oh, they don't need any supports in school, she's so high functioning. It's like, no, there's still needs, like, yeah, things are still hard, it's like people are kind of missing the mark. And again, someone who's so-called high functioning in many circumstances could, in the context of being, autistic burnout and complete meltdown or overwhelm, it could look really different. So I just don't find these functioning labels to be helpful, useful, or accurate. And I want to just see assessment as more of an opportunity to help these families reframe challenges, better understand their kids. I think that, this sort of expert stance, like, these are the things we have to do in this assessment, right? I think that assessors need to be more flexible. I think that sometimes we really know how a kid is going to struggle with a certain task. So why are we making them do that, right? I think there's other ways that are more ethical to come to an autism diagnosis. And when you hear about what all the hoops and all the testing that some of the families have gone through, it really, it does not fit well with a neurodiversity affirming framework. And I also want to tell kids that they are autistic, right? And I know that, parents have feelings about this and that are valid. And I think that, in general, we want to meet parents where they're at with, their own process of accepting a diagnosis if this is new to them. But you'd be surprised, like, it's not uncommon. It's like fairly common that people are not telling their kids that they are autistic. And, several thoughts about that. One is that not telling them that they're autistic kind of conveys that this is like something secret and shameful, that we need to like sweep this under the rug here, and what's that kind of messaging, right? Two, they might find out anyway, and they often do, right? They might find out from a teacher, a therapist. It's, it's written in an IEP, and if we are kind of getting ahead of this, having this conversation, it's an opportunity to have a more neurodiversity affirming way of talking about autism, not just in terms of challenges, which we know are there. We're not pretending like there's no challenges, but to also talk about the strengths and how this plays out for the kid. And so I definitely think that we should be talking to kids about it and putting it on the table. And again, it's this over focus on the autism as a tragedy paradigm that gets conveyed from providers often to the, in this diagnostic process to families, that I do not find helpful. I really think, again, when we use, less pathologizing language, when we talk about the child and their differences better, when we eliminate these billboards I mentioned, talking about how, autism is a crisis. Let's be aware of this. And we need to, like, these things just, contribute to an autistic population that might not be feeling that good about themselves, right? So how can we be more positive about that and get out of that paradigm? And really rethinking how we support, autistic people and their families. Like, it's so common for, like the messaging from the initial diagnosis, like early intervention, we can get your kid like to a certain level, right? But the goal is not for your child to be neurotypical. And I think that's worth repeating. Like, the goal is not to be neurotypical, because it doesn't work, can lead to masking, which is harmful. And it is not neurodiversity affirming. It doesn't accept the child for who they really are. So we want to really get out of that. And we want to be in any type of therapy that we're considering. We want to be thinking about how does, like, is that what this is really going for? Right? Or is it really going for kind of helping to manage anxiety? That's different, right? Like if we're helping somebody to, previewing what the dentist is going to be like, and, like to make it a little less anxiety provoking, that's different, right? Like that's not trying to make the kid neurotypical. That's trying to support a kid and make something easier for them. But when therapies, when I say like this, we take this, this diet and, like all the autistic symptoms are gone, or, like this therapy, you won't be able to distinguish your kid from a neurotypical kid. Like it's the wrong goal, doesn't work. So we want to get out of that. So who needs the social skills training and who needs the behavior plan? I talked about this earlier, right? So, there's an autistic researcher named Damien Milton in the UK who talks about the double empathy problem. And, it's not just that, autistic people might have some difficulty understanding or empathizing with non-autistic people. It goes both directions equally, right? Like the autistic and non-autistic population are not understanding each other that well. So maybe we should be doing some training of neurotypicals to sort of be more accepting of autistic people, right? We're not, we don't want to have these sort of social skills training programs where the goal is to make the child seem normal. It might be important to, give child opportunity to, to get support and connection with other kids. Shared interests are really important to kind of find that. But our goal is not to make the child neurotypical, to say for a third time here. So I really think it can be, it's like almost like a misuse of resources, spending so much time trying to change the child, but what are we doing to try to change the system around the child? That's where I want to shift here. There's been a lot of, this quote is from, I'm forgetting the name of the book. I think it's a ADHD, a book, a guy who wrote, about adult ADHD and ADHD in children. Ed Hallowell, that's the name of the author. The treatment of children who behave badly has been terrible throughout history. I mean, it's true. Like we have not done well with children who have behavioral challenges. And in fact, I think it's really important to keep that historical view that like autism therapy has really only been around for like 40, 50 years, more or less, right? That is not a long time. And I think that to get stuck in like, well, what we're doing now is right. Like, we need more time to develop this. And so I think that, and so some of the problems that I see that is really important is this problem of overemphasis on compliance in ABA, right? And like when we're teaching a child, you must comply, even if your sensory needs are making it difficult for you, or your emotion regulation challenge is making it difficult for you. You must comply at all costs. That's a real issue. People need to have a right to say no to things, right? And I think, when we see more autistic people speaking out about some of the harm that they feel ABA has caused, like that's really important to listen to and to take really seriously. And I think autistic people need to have more input into the design and the goals of therapy. That gets into the concept of self-determination, right? Like what does the autistic person want and how do they want to be, right? Rather than us imposing our ideas, right? And sort of, onto them, which I think is a really important piece too. So I don't know who's heard of spoon theory, and I really like this. I really like spoon theory as applied to the autistic population. So spoon theory comes from somebody that is an adult with a chronic health condition that I think is lupus, I believe. And what she talked about was through her, physical issues and fatigue, challenges with fatigue, is having a certain amount of spoons. And spoons is kind of a metaphor for like units of energy or like emotional wherewithal, I think is a way that I think about it. And, some kids, they have, like getting through a school day might take a lot of their spoons, right? And then, but maybe they're required to do, some kind of therapy program after school that's just too much. They just don't have the spoons for it, right? Or maybe the week was too overwhelming. We're kind of taking a like an emotional temperature of your kid. Like, do you have the spoons to do this? And I don't think that we think that way that much, right? It's like, what are the adult expectations? Let's try to get our kid to do that. But I want to be tuning into, like, what does this kid have the spoons for here? And that gets into having the right level of expectations for a kid, which I see time and time again is one of the central issues in behavioral challenges coming up. This can go in both directions. So, for example, sometimes, like, okay, a kid has an IEP and an autism diagnosis. Like, it doesn't mean that they can't learn or can't be challenged. Of course, we want to challenge the kid to where they're at, right? But what I see more often is that, well, we are expecting this kid, because of hidden disabilities, ones that are not as apparent to us, like executive functioning issues or remembering to do chores or having enough emotional energy or spoons to get the homework done after the school day, is, like, we're expecting things that a child can't do, right? Not that a child won't do, but that a child can't do. And so we really want to make sure that we're having the right level of challenge, tuning into, like, where is my kid at? Where is my student at? Where is my patient at? And what can I be expecting of them, right? And finding the right level of expectation. So, in talking about neurodiversity affirming therapies, right? So, as I talked about earlier, a big fan of Ross Greene, who wrote The Explosive Child. He's the psychologist, talked about the collaborative and practice solutions approach, just really a very respectful approach that really incorporates the views of the child. It's like, rather than the adult imposing so-called solutions that may not be working that well to prevent challenging behavior, how do we engage kids as a collaborator in solving their own problems and be more flexible as adults in finding the right level of expectations? Really, really, really well done therapy, has research support for it. Really a fan. Attunement to sensory issues. I mean, this is a really, really important point, right? That I think that still, even though we know over the recent decades that, the role of sensory processing is really critical in thinking about behavior challenges or regulation, we still don't have enough attunement to sensory processing issues. We still don't have, insurance companies that are covering sensory processing supports. No therapy at all I have here is a question, right? Because sometimes parents come to me saying, like, like I was, when I got diagnosed a while ago, when my kid got a diagnosis, I was told, like, okay, like, let's do these 3 days a week of ABA, and one day, 3 weekdays a week after school, someone's coming over for 3 hours. And the other days got this other thing going on. Like, can I stop? Like, I hear that. I hear people asking me, and it's like, yeah, you can stop, like, we have to know it's not the diagnosis that gears the program. It's the child that influences what the program is. And for some kids, it's just too much, right? Maybe like a shared interest Minecraft group online or something like that. Sure. Right. Like, this kinds of things are great, but maybe we're just like doing too much for a kid. So sometimes pulling back from therapies actually is helpful, somewhat ironically. Again, focusing more on well-being and support without all the appointments, right? Another neurodiversity affirming approach is really making sure we're looking at behavior as communication. I think is a really important piece, right? It's like, for kids who are non-speaking, there's a lot of communication going on still. And are we really listening to what that communication is? The low arousal approach, I'm a big fan of. So I've learned a little bit this. This is also coming out of the UK. And it's really, again, focusing on, I think, the caregiver changing more than the adult or the child, who has a disability changing. And it's really a focus over the stress more than focusing on the behavior itself. So how do we manage and help the stress over the behavior? And it's a really lovely approach that I think fits into a neurodiversity affirming care. Offering multiple modes of communication. Like, there are some kids that, like, in these dysregulated states, we're using all this language as the parent, as the therapist, as the teacher. Like, a kid just can't handle that. But maybe they could just, like, put up a 1 or a 2 or a 3 on their hands to communicate, like, how much something you said resonates with them. or maybe we need to just back off and not try to use so many words because it's not actually helping. We need to be reflecting on that too. More recently, I've done a little research into Ukeru, which is a crisis intervention approach. That's, I'm sure, Guy, you know about this. I think you've talked about this, which really is a great alternative to using restraint and seclusion practices in I think I've seen it applied in some residential facilities. Some really been learning more about this approach, which is really lovely. So there are some neurodiversity affirming therapies out there, and I think we want to see more of it. So here I have listed some resources that I think are great. So the Autistic Self-Advocacy Network, ASAN, wonderful. Autistic Women Non-Binary Network, Lydia Brown at autistichoya.net. Been really doing a lot of reading through the Therapist Neurodiversity Collective. These are, there's the website listed here. And this is a collective of speech therapists, OTs. I think it's largely those two groups that are doing really amazing work. Neuroclastic.com, really great writings from autistic authors. I found that really useful. I've been really digging into that lately. The PDA Society, here I have the website listed, I think is great to learn more about PDA and approaches from them, because I think that's a really neurodiversity affirming framing and approach to working with kids. Learnfromautistics.com. That's something I've also come in contact with more recently. I think it's a parent of an autistic kid who wrote that, but it's like really kind of collecting the views from autistic adults about parenting and therapy in a really sort of organized way. Alfie Cohen, who I think some of you may have heard of, is another clinician who talks a lot about alternatives to behaviorism and some of the problems of behaviorism that I would really recommend looking into some of what he's done. And Mona Delahook, and Guy, I know that you've connected with her, and I think had her on the show, and she wrote Beyond Behaviors, and I think more recently Brain Body Parenting, which is next on my list. I really want to read that. I think Brain Body Parenting came out more recently, but she's absolutely advocating for more neurodiversity affirming approaches. So there's some resources, and that is the end of the presentation. So I wanted to see if anyone has any questions, comments, concerns, thoughts that's come up.
Hey, Alex. So I'm going to come back up here, and you're welcome to close out your presentation if you'd like, and that way you can again see the screen here, so you can just kind of move off of that back to your Chrome tab. And we do have a couple of questions that are queued up, so I'll start going through a few of those. And it looks like we're back on the same screen now. Alex, that was really great, and I've got to tell you, my neck hurts a little bit from going like this. So much you said, was resonating with me. Yeah, and I saw the same coming from our audience as people were looking at things. So I'm going to first begin by going into some of the comments that I saw here, and I'm just going to go back a little bit here. And this was a comment from Ruth Ann, who talked about forcing eye contact, and once having a therapist who said I wasn't being present because I wasn't looking at her and I was fidgeting. It was so frustrating. And Ruth Ann, I can think back to an experience that I had with my son, where for many years he had a goal in his IEP about making eye contact. And one day, as I became more aware and more enlightened, I suddenly stood up and was like, no. Cooper does not need to look at anyone. In fact, he can be looking, at something entirely unrelated and be listening to the three conversations that are happening around him. But the tendency from, I love that you touched on the medical model and the social model, but the tendency in the medical model is really to, kind of pathologize the behavior, to look at it from a deficit standpoint, and to try to make everyone the same, to try to make everyone neurotypical. And that's such the wrong approach.
And I'm sorry to hear with him that happened to you. And unfortunately, it's really common, right? It's like there's one right way to be. We must make eye contact. Like, no, we really want to get out of that, sadly, a lot of people are having that experience. Yeah.
Mm-hmm. So Darlene here said, when professionals talk about autism to parents, it's always negative, which kind of underscores what you were saying. It scares parents and makes them panic. The panicked parents try to go out and get as much help and support. There really isn't enough support for families. How can we change that model? And I guess there's really two things to address there. One, this idea that Parents are being frightened, but two, even beyond that, I hate to say this, but many of the approaches that are being recommended today are not neurodiversity affirming, are arguably very harmful to kids. So, Alex, any thought? I mean, I know when we introduced you, we talked about how you're doing training, and I thought I always love to hear people that I think are just really people that kind of get it and they're heading in the right direction that are doing training, because that means there's a spread of good information. But even if we were to look at people coming out of professional programs today, it seems that there's a lot of old and bad information out there that's still being taught. How do we change that?
Whew, yeah, I mean, I think there's some there's a long way to go, right? I mean, but if you just look, at like the kind of list of presenters and the topics that people you've brought on the show, like there's some seeds here where we're, of like a little bit of growth, right? And I think, introducing these other, like the Mona Delahooks of the world to, like brain body parenting, to a school, to an organization. I think, to answer the question, I mean, part of the issue, right, is that like, that I think part of what needs to change, like I was saying in the presentation, was the way that professionals instill the fear to the families. Like, this is an emergency, right? And it's not an emergency. It's not an emergency. Like let's slow down for a second here, right? So it's like the messaging to families is really critical. But yes, I do think families need more support. I think there needs to be more funding. I think we need to be advocating on a statewide level for more funding for parent support groups, for family supports, for regional centers. It's called different things in different states, right? Before, regional centers would be providing more supports, right? So absolutely, there's an advocacy issue to provide more funding and more support for families going through this process. I agree with that.
Yeah, absolutely. And you mentioned Mona. I had the honor of being on a program earlier this week with Mona, actually, that was being held by the Psychotherapy Networker magazine, and of course they have broadly an audience that are a lot of professionals, and we were talking about Mona's work in restraint and seclusion, and anything we can do to continue to highlight the work of people like you and Mona and others that are really trying to push us in the right direction. But systems are hard to change. And, it's really frustrating. Even when I look at, what are coming, what people are coming out of university programs with, that are going into schools and working with schools. You brought up, when you talk about autism, like the ear of the refrigerator mom. And of course, everybody would look at that right now and say, oh, well, that's absurd. That's ridiculous. That was in the 1950s. Yet, in many of our schools and many of our institutions, we're relying on science from the 1930s and 50s in terms of here. But
we haven't caught up with the latest neuroscience.
That's right. That's right. Which is really frustrating to me. I mean, when we simplify behavior to simple functions and don't really take into account the brain, trauma, any of those things, it's just such an incomplete look. But that's still widely what's being taught. So, changing these systems is really tough.
Yeah.
So a friend here in New Zealand, Linda, and Linda says that she's actually watching this over breakfast. So we've got people from all over the world that watch. I saw somebody else from Scotland. And Linda says, as with the DSM, often it is the tools, quote unquote, that professionals use that generate the deficit labels. EG or OT sensory assessments that was used with one of our students recently was full of language like problem behaviors.
Yeah, and and I mentioned that a little bit in when I was describing some of the language and some of the autism assessment tools I use as a psychologist. And so, first of all, we need to be doing more research into having better tools out there, right? And I think for adults, there's some things that I'm seeing, like for example, something called the CAT-Q, the Camouflaging Autistic Traits Questionnaire. Like, okay, this is an improve. Like this is, if you look at that, like the language is not that pathologized, but most of the stuff out there really has a lot of these over pathologizing things. And I think that, like, if we have to use them to get a diagnosis, I do think it's important. Like, so for example, maybe if we don't use certain tools, then the kid's not going to get a certain diagnosis that would provide access to important services. Right. So we think we, have to use some of these tools for practical purposes sometimes. But I think sometimes it's important to have that conversation with the family. Like, I do not like this is not a great framing of it. Right. And you can help families to think critically about that as well.
And Linda followed up with, what are your thoughts of the ADOS-2 assessment tool?
Ooh, good question. I'm no longer a big, I was never loved the ADOS. I think that it is.
And just for people that may not know, that's the Autism Diagnostic Observation Schedule, right? Okay.
Yeah.
Okay.
So that's a pretty standard, certainly in the States. I'm not sure how it is worldwide, but very standard. Sometimes some places considered the gold standard for autism assessment. So I'm not a huge fan of it for older kids and teens and adults, because I think some of the questions can come across as a little condescending. I just don't think it's often necessary to get to a diagnosis. I think that the way it plays out with a toddler, I don't think it's, that bad. And yes, I think we can get some useful information from doing an ADOS. I just try to avoid using it with the older ones, because I just think that, this is based on conversations I've had with autistic people and telling me about their experiences with the ADOS as this assessment just felt kind of condescending. So again, it's well, what's really necessary to do to come to an autism diagnosis? And it's not always necessary.
A comment here from Ruth Ann said, yes, I agree so much that parents should not hide an autism diagnosis from their children, and went on to said that my parents never told me that the neurologist thought I might have Asperger's when I was 5, and they never pursued an official diagnosis. So I did not did it on my own when I was diagnosed at age 21.
Yeah, and I think that one of the challenges there is I have some empathy for parents. They're born into the same ableist system that we all are, with all the stigma and negative stereotyping. And I do think that parents sometimes believe that they're doing something helpful, or I can, but it's hiding this diagnosis. We're not giving kids and teens and young adults the opportunity to maybe understand themselves. Well, why is something kind of different for me? Is there a community out there of people that are more like me? Right? This is a really, really important thing that I think we miss in this. Yeah.
So Aaron says, this is wonderful information. No one at my child's school has asked her what she needs to succeed while they create compliance goals for her. I have such a issue around the compliance focus that exists in so many of our schools. And again, there are exceptions. There are places that are doing fantastic work. But, I think about this idea of compliance, and no parent I know, and you're a parent, you can relate to this. If I said to you, Alex, what are your goals for your children? I'm sure compliance would not be at the top of your list. We don't dream of our kids being compliant. We dream of them being kind. We dream of them being, whatever they might want to be. But compliance is not one of those things. Yet many of our systems are really focused on compliance.
I know. And, it's that framing that would we think of compliance as the ultimate goal, that I think leads to things like restraint and seclusion. I mean, I recognize that can be thought of as a little oversimplified, but I think there's truth to that, where it's right. That is the sort of philosophical framing that leads to these harmful practices. So yeah, I mean, I think it's good to be pushing back on that, and I agree with everything you said. Thinking Person's Guide to Autism. Yeah, thank you for including that. Actually, I'm going to add that. Thanks, Diana, for adding the Thinking Person's Guide to Autism. It's another great website with a lot of articles that are excellent.
And I'm not familiar with Autistic Science Lady, so that's
yeah, I didn't know that one either.
Yeah. So another great resource.
Yeah.
All right. So I'm just going to continue to go through some of these. We've got a lot of comments here. Ruth Ann again said, but I do agree that many times behavior is communication, but I guess it's important to be aware that it not always is. So Ruth Ann said that I've learned from Neuroclastic that not all behavior is communication. And I'm not sure exactly where you might be headed with that, but I guess the one point that's really that I've learned from the work of people like Mona and you and others is this thought that not all behavior is intentional. A lot of people look at all behavior as being a matter of intent, that kids are making choices. And that's where we get things like you need to make better choices. And the whole idea that we've got kind of these bottom up behaviors that are really kind of coming from our nervous system that are protective. And, I really think does change a lot of the way we look at things. Thoughts?
Great. Yeah, I mean, I really, really agree with that, and I think I think some of the reasoning that I wrote, talked about thinking of behavior as communication was just around how sometimes I think actions, movements that are not like typical speech or the way are not always taken as seriously, right? So, like for example. I had if I've had, I can't speak specifically about clients of confidentiality issues, but I can speak kind of generally, that I've had clients where there is a medical issue that, they couldn't really tell us about, right? But they were starting to kind of like hit their stomach in a certain place, right? And it was like, do we have a physician that's willing to sort of like think broadly about what this behavior might be communicating, right? But I agree, not always, but sometimes it's important to tune into these things, and maybe particularly with a non-speaking population.
Yeah. And Diana said, again, nodding profusely. So you had a lot of that. Angela asked a question: are there resources for people who use the court system to mandate ABA for elementary age children? CPS is a real solution and better and more affirming.
That is a great question. I don't know. I think you can point people towards the research for the collaborative and proactive solutions model. And Ross Green's website, Lives in the Balance, has a lot of free stuff on it, including a list of the resources or the research.
Right.
So,
and of course, it is evidence-based as well, which,
yeah.
All right. Let's see. Aaron said, instead of compliance goals, what should a goal look like for verbally aggressive behavior and or task avoidance?
Yeah, well, the first question becomes like, well, why is the child, becoming verbally aggressive, right? Is it because, why is the child avoiding the task? Are we picking the right battles? Are we, is this expectation that this child write for 20 minutes the right expectation? Or is it that too much, right? And that maybe they should be able to just write about Minecraft for 5 minutes and that's it. And that's all we're expecting right now. Maybe we can gently try and stretch it, right? So maybe the goal, is like, I would say the goal has to be more about sort of meeting a child where they're at. And then just for anything about verbal aggression, right? So this has to do with just like emotion regulation in general. So it's not so much like the actual words that come out, but the internal experience the child is getting dysregulated. I mean, the goal, I would say, is like for the child, for the adults, for the aide, the teacher, the therapist to notice like, okay, is this child, getting a little more dysregulated, getting more stressed? Like what are the tools? So a goal might be adults will notice first signs of stress as A, B, and C for child, and therefore will do this particular self-regulation strategy or regulation strategy. We'll be able to take a break, right? So I think the goal is around noticing what's causing the frustration, being able to kind of prevent it before we get there. Because once we get to the point of like full-blown red zone verbal dysregulation, we're kind of too late, right? It's why, we think of when you get to a point of restraint, or an exclusion, or a kid's totally dysregulated, it's like multiple things that we missed along the way. Because once, so I think, backing up, going upstream, looking at, what the roots of that are. Really.
Yeah. And really digging deep, right? Really digging deep into, right now, Stuart Schenker has kind of come into my head here. And one of the questions that Stuart asked is why and why now? So why are we seeing that behavior? Why are we seeing that behavior now? Digging deeper to try to understand what might be leading to that. And as you mentioned, these behaviors are often a response to stress. So what are the stressors that might be on that child and giving that child a difficult time? That's all right. So I'm going to keep going through a few here. Ruth Ann says, some of my main passions is how do we teach psychiatric hospitals to help autistic people?
Yeah. I mean, I think in general, it's important for medical schools, for the grand rounds that many hospital systems do for training to sort of incorporate these ideas and neurodiversity affirming care, into the education, into the training, right? So I have done some of that with residents here. I work one of my jobs at Kaiser Oakland Medical Center, in addition to private practice, where we do some of that. We do train residents, we do train graduate students, but it's a process, right? And psychiatric hospitals, I think it leaves. I know a lot of autistic patients that have not had great experiences in psychiatric hospital. They've not really adequately understood autism and autistic features. So, I think it speaks to a need for more training, more resources, more support, more specializations. And I think that's an important point, that they're not good enough, and that there's a lot of problems there.
Yeah, one of the things that I've found, Alex, is that there are acute psychiatric facilities across the nation that don't do things like restraint and seclusion, but there are many that still do. So this kind of issue, that we're talking about, kind of the compliance, the control approaches, are prevalent in some of these facilities. And the thought process is that we have to do these things. We don't like to, but we have to do these things. But we also know, I mean, I talked to a few folks that worked on a project probably a decade ago to reduce and eliminate restraint and seclusion from acute psychiatric facilities. Absolutely a possibility. But, like schools, some hospitals, some institutions are further along than others. And, again, it's about how do we spread the better practice and get people, really doing things that are going to be, not just better support for, neurodivergent individuals, but for any individual that might be in crisis,
Yeah, absolutely.
Yeah. And Linda just said, I like what Dr. Klein said about goals and the plan being for, I caught this too, for the adult and the educator, right? I love that. And I'm glad you brought that up, Linda, because as you were saying that, I'm like, yes, yes, yes. We see a tendency to make it all about the kid. How are we going to fix the kid?
Right.
But, like you and I had talked about low arousal before, and low arousal, so much of it is on how do we change the way that we respond to a situation?
Right.
How do we handle it differently from our part? And that's such an important point.
Yeah. Love that.
Let's see here. I'm gonna get a couple more, and then we will wrap up and let you go, because I know that I don't want to keep you here too long. Diana again said yes, because focusing on behaviors is a vicious and exhausting cycle. We certainly see that a lot. Aaron again kind of asked and said, I'm trying to get my school to change their expectations and meet my kiddos' needs, but it's so hard. And Aaron, one thing I would say to you is, one of the things you might want to do, and I've done this before, is, get a couple copies of a book like Dr. Ross Green's Lost in School, or Dr. Mona Delahooke's Beyond Behaviors, and share those with your IEP team. These presentations that we do, one of the hopes is that people will share them, and we want to see parents sharing these with their teachers, with their educators. Our group, the Alliance, is really made up of a lot of parents of kids that have gone through and experienced negative things like restraint and seclusion, but a lot of kids that are being kind of pushed down in various areas related to their behaviors. But we also have a lot of self-advocates, tremendous number of autistic self-advocates. We've got teachers, we've got educators, we've got administrators. And the point is, these are all things that we can do to change systems. So please don't hesitate to share these programs that we do. They're also all available on YouTube, which tends to be a better platform than Facebook for sharing things. But share things, share books. Alex, other thoughts?
Yeah, I mean, I would just say that sometimes, it's such a battle. I just such admiration for. I know how hard parents are working to get the school to change and advocating for their kids. Really impressive, and it's so hard sometimes. I think that often there's like one or two people in there. Like it's mostly. I think there's sadly are exceptions, but like it's not every single person that is like kind of contrary to you. Like sometimes you find one or two people, right? We like latch onto those people and try to keep them as close as we can. Like that one speech therapist, that one aide, one teacher who really got my kid, and how can we sort of like team up in these IEP meetings to sort of, try and support the kid as best they can. But yeah, and I agree with what you said, Guy, about, like also sharing the resources. And I think talking to the schools about like, well, what's really working? Like, yeah, you're trying to, like if we don't change our expectations, like what you're doing right now, like isn't working. Like, let's try something else, right? And I think schools really need to be listening to parents more, of course. But I know it's a battle, and I know it's exhausting.
Yeah, and you're right that it amazes me that sometimes anyone will continue to do something that's not working because they believe it's the right approach without really stopping to take stock and go, this isn't working. We're seeing more behaviors. We're seeing increased behaviors. And Diane mentions here that, her kiddo's school is also escalating her child. And, unfortunately, that's something that we see a lot when we look at, kids that are restrained, secluded, suspended, expelled, all these things, is that often it's a well-intentioned but not really appropriately trained staff member that not only fails to escalate a kid who is beginning to escalate, they actually end up escalating them. When they're putting more demands on a child who's already having a hard time meeting the demands that are on their plate, the child begins to escalate. When, as you said, they become inflexible when the child is inflexible. An inflexible kid and an inflexible adult, is going to escalate. And, sadly, we've seen many instances where kids end up getting physically restrained or secluded because an adult has inadvertently really kind of ratcheted up the temperature and not realize as that kid really gets to a point where they are getting to that fight or flight state, that their prefrontal cortex is going offline. The thinking part of their brain is not available. And, it's unfortunate, but we see that approach really commonly. So Michelle said, I would love to collaborate with Alex, and Michelle is with
can you put my email in the chat? It's the dralexklein@gmail.com.
Okay, let me,
because I'm not able to access the chat.
I'll grab that in 1 second here, and I'll put that in. And we'll just take a couple more, and then I'm going to let you go here. Let's see. Oh, wow. We just had more and more coming. A lot of engagement here, Alex, which is always great. But probably more questions than we're going to be able to get to today. Let's see. I'm just going to take a quick look here. Let's see. This is kind of a long one, but Spectrum Life, who participates very often, it always has great input to add. And this was on a comment about verbal aggression. Says, I'd argue that dysregulation being very high is a primary reason for any level of aggression. Stressors have already added up tremendously to get to this point. So schools must ask, is the environment overstimulating or understimulating? What are the students' sensory profiles? Are their cognitive communication needs being respected? Are they being accommodated? Are the demands appropriate? Is the student dealing with physical/mental health symptoms, and kind of goes on. But really, all again, great points. There's so much beneath the surface, and this is why I always get really kind of passionate and frustrated by a lot of the approaches to looking at behaviors in schools, when they just boil it down to here's one of the 4 functions of behavior. We think it's this. Here's an adult hypothesis. Let's solve the problem. We really need to dig deeply when kids are having a difficult time, understand why it's happening then. And I remember talking at one point to occupational therapist Greg Santucci, who I think really highly of his work. And we interviewed Greg, and as we were talking, I had this like moment where I'm like, it's not even just about doing a functional behavioral assessment. We need to be doing environmental assessments. We need to be looking about what in the environment may be making it hard for a child. And so often, again, the focus is on the child. The focus isn't on the adult who may be, and when we see this, we see a child that has a lot of difficulty in environment 1, moves into another environment with different adults. Child hasn't changed. The adults have. The child's a different child. So there's so much more we need to look at. And thank you, Spectrum Life. That was a great point. So with that, again, we've covered a lot of ground. I think we could probably talk for another hour, but I want to be respectful of your time. And I know we had a few technical issues here early on. Before I let you go, though, any final thoughts? And again, I'm going to share your email, but I want to give you a chance to share any final thoughts that you might have.
No, I mean, just to respond to a couple of, the comments. I mean, I just think the comments speak for themselves. I think it was in response to one of the questions a parent asked about verbal aggression, from Spectrum Life that sort of comment response speaks for itself. But I'd say like that is really the core of it. So I want to highlight that response and just say, to you, Guy, thanks so much for the work you're doing. I think this is a really, really critical, important piece. And thanks for bringing us all together and talking about these important topics and for the work you're doing. So really appreciate it.
And mutually, I really have a lot of respect for what you're doing. When I saw you give a presentation that was similar to this, I was like, oh, we've got to have you on
Right.
and talk to you. So thank you so much for making the time today. And,
Welcome.
really appreciate all that you're doing to make a difference. And I'm sure we'll be connecting again. One of the things I can tell you is that, once you're on this show once, I'm probably going to be after you again to come back.
Love it.
I'm going to share a real quick announcement here, but you can hang out for a second if you'd like.
Sure. Yeah.
And that is that we've got another event coming up in 2 weeks, and this one you might be interested in.
Yes.
Alex as well. We've got
recommend
Mona Delhook joining us again, and this is actually Mona's, I think, third time joining us. And I actually was on an event with her earlier this week, and she's going to be joining me. We're doing a one-day event on May 11th, and it's about reducing restraint and seclusion use. It's a training event that we're doing, and Mona's going to be joining me for that as well. And of course, you mentioned her new book.
You got it right there.
I have it sitting right here, and was fortunate enough to get a copy of this very early, and it's fantastic, and I think very attuned to the kinds of things that we've been talking about here today. So for all of you that have been watching, just want to thank you for joining us as always. Please share these events with others that you know, and we look forward to seeing you again. So with that, we will wrap up the broadcast. Alex, if you want to hang around for 1 second,
Yep.
I'll let you go. Thank you so much.